Welcome to another installment of the DUTCH webinar series. I'm Dr. Kelly Roof, a clinical educator here at Precision Analytical, makers of the DUTCH test. In today's session, we're excited to welcome Dr. Allison Smith, who is presenting today's webinar called Depression and the DUTCH Test, a Holistic Assessment. Her presentation takes a deeper look at depression being a multifaceted condition, highlighting how hormones, the stress response, inflammation, and even gut health can all play a role. In addition, she'll explore how providers can use the DUTCH test to better understand what's going on behind the scenes and explore more personalized supportive treatment options. We're glad you chose to join us to gain valuable insights into a more effective and integrative approach on this topic. Dr. Allison Smith is a naturopathic doctor who completed her education at the National University of Natural Medicine in Portland, Oregon. She has worked in private practice focusing on primary care, women's health, and dermatologic laser therapy. Over the last 10 years, she has consulted with providers on thousands of cases in the context of hormone testing and brought awareness of testing to providers in clinical practice through consulting, webinars, case presentations, and articles. She now leads an esteemed lineup of clinical educators at Precision Analytical, home of the DUTCH test. If you're ready to start using DUTCH in your practice, sign up as a registered provider today. It's really easy. Just click the link we've posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so you can begin to take advantage of all the education and all the resources that DUTCH has to offer. Plus, registered providers gain access to our entire educational library, including courses like Perimenopause Management, which just came out, Introduction to HRT, Mastering Functional Hormone Testing, and the DUTCH Interpretive Guide, and one-on-one consultations with DUTCH clinical educators. This dedicated support and education is designed to help you become the hormone expert. If you have any questions as we go, please submit them and we'll do our best to address them in a follow-up in the days ahead. So also be sure to follow us across all social platforms to stay up to date. It's a pleasure to have you with us today, Dr. Allison. Take it away.
Thank you, Kelly, for that wonderful intro. I am so excited to share my experience with all of you today as we learn more about dried urine hormone testing for diversifying our assessment of depression. Before we get started, all of the slides that follow are provided as information resources only and should not be taken as individual medical advice or as a substitute for professional diagnosis and treatment. Today, we're discussing an integrative assessment and approach to depression, which is multifactorial at its core. It's about so much more than just neurotransmitters, which explains why up to half of all people given pharmaceutical antidepressants don't fully respond. So there's a huge need for an individualized approach that pulls in other parts of the etiology. So we'll explore what those factors are and how to identify them on a DUTCH Plus test. Then we'll walk through a DUTCH Plus report to show you how to build that assessment and get you a little more comfortable with putting together a comprehensive plan. As we get into our topic, here's your abbreviation key for future use. Now let's dig into depression. Depression is defined as the persistence of low mood and loss of interest in activities. It usually presents with other factors like fatigue and sleep problems as common ones. If you're in primary care, you have a lot of patients who are struggling with depression in some capacity, whether it be mild, moderate, or major. It can also be acute or chronic or recurrent, but it is highly prevalent. By 2030, it will be the leading contributor to global disease burden, if you can believe it. Commonly, those with symptoms of depression are prescribed psychotherapy along with some sort of monoamine reuptake inhibitor like an SSRI. But there are some new therapeutics like esketamine that are gaining traction as well. There are also physical therapies like electroconvulsive therapy and TMS, but these aren't available everywhere, so access can be an issue. So meds currently are the mainstay, and SSRIs are the most commonly prescribed. But only about half respond to first-line monotherapy, so it can take a long time of trial and error to figure out if a patient is going to respond to treatment. For those that do respond, little is known about the long-term effects beyond, or the safety beyond a few years. And there are side effects too, like weight gain, which can decrease adherence. Now, sometimes the medication trials don't work at all, as in treatment-resistant depression, and many patients choose to discontinue therapy on their own. So we start to see there's a need for a more diverse approach to treating depression. Depression is a complex clinical syndrome which has a massive prevalence worldwide. We're talking about 280 million people. This is huge. There's been a slow movement towards more diverse therapeutics, which has been helpful. They address other neurotransmitter systems like glutamate GABA, and we're starting to see those start to enter the market. But I love this paper because they really explore other equally relevant causes of depression, like inflammation and HPA axis dysregulation, as etiological factors. At its core, depression is a disease of low-grade inflammation and immune activation that engages the stress system. In fact, there are even key inflammatory and immune kind of signatures that are associated with different types of depression. Like the melancholic type, we see high interleukin-6 levels with fatigue and sleep issues with that. With atypical type depression, it's not uncommon to have high CRP and leptin with weight gain and appetite disturbances. So it's fairly well understood that there's an inflammatory underpinning, an immune underpinning with depression that needs to be explored. So let's review the HPA axis, since it's responding to inflammation and immune and these types of stressors in the body, and see how it relates to depression, particularly through cortisol being too high or too low. With a little review of adrenal production of cortisol and DHEA. So the adrenal glands produce several hormones, cortisol and DHEA, as well as aldosterone and norepinephrine and epinephrine, also known as adrenaline. When we're presented with a stressor, our catecholamines, norepinephrine and epinephrine, are pumped out of the adrenal medulla at the core, and they respond first. Cortisol is slower to initiate, but its effects last much longer, so it's what's responsible for kind of increasing blood sugar and sugar availability to our muscles. It changes the way we metabolize fats, it increases our blood pressure, and overall supports the fight or flight response. After that stressor is resolved, there's stress being resolved, those high cortisol levels then feed back to the hypothalamus to decrease the signals for its own production, right? And that cortisol returns to baseline at that point. And this works really great under acute stress situations where the stressor is resolved. However, chronic stress and prolonged HPA activation can affect neurotransmitter systems and influence mood and cognition because that negative feedback doesn't work under chronic stress situations over long term. The DUTCH Plus assesses HPA axis function. I want to show you how to look at HPA axis function as on this free cortisol graph here. So here's a normal stress response to waking and a normal diurnal pattern of cortisol as depicted on the DUTCH. Notice the cortisol awakening response in the first 30 minutes of being awake. It should be a tight 50 to 160%, and it is. That looks pretty good. And then it should return kind of to baseline waking levels just about by 60 minutes after that stressor is resolved. And that would be a normal cortisol awakening response. For the diurnal rhythm, we want to see a general drop of cortisol through the day. So you want to wake up much higher in cortisol production than you do when you're going to bed at night. You should be at your much lower levels at bedtime, and even lower in the middle of the night. The trajectory is nadir, lowest levels of the day about 2 in the morning in the middle of sleep. So once you've assessed the shape of the diurnal pattern in the car, we can then assess the overall levels of cortisol throughout the day. And with high cortisol, we worry about the hippocampus and the prefrontal cortex, and they could be damaged with high cortisol. And we can see emotional lability and depression, while on the other side, with low cortisol, it goes more with irritability, apathy, depression. So we really must assess cortisol levels when we're approaching anyone with depression as a presenting complaint. We want to normalize it. Here are some examples. High free cortisol pattern up top here is suggestive of that high interleukin-6 type of depression, the melancholic type. This type tends to respond better to antidepressants than the flattened slope type, which is down here towards the bottom. Flattened slope is more associated with chronic depression and treatment-resistant depression, and that atypical type. Now here is how cortisol is reported on a DUTCH test. The graph on the right is the free cortisol. On the left, we have the free cortisone. Free cortisone is simply a secondary measure of free cortisol and a nice way of confirming highs and lows. But we measure the CAR using free cortisol in the graph on the right. And we see here that this person has a very elevated cortisol awakening response, and that suggests that the HPA axis is overreactive to normal stressors, right? 500% rise is too much. The CAR should normalize with appropriate treatment. Now, sometimes the CAR is prolonged. It'll have an initial rise in cortisol. In this case, was 180%, which is elevated in itself. Doesn't quite get it up into the normal range, but still, 180% is a pretty, active awakening response. But what it doesn't do is return to baseline. It continues to rise over the next 30 minutes. So this is what we would call an elevated and prolonged cortisol response to stress. A high and prolonged CAR is a hallmark of mild to moderate and acute depression. So think acute with the high cortisol awakening response. And the HPA axis is producing cortisol essentially at a higher level than the need entails. When the CAR is high, cortisol increases epinephrine production, which can contribute to anxiety as well. So think about anxiety with the elevated CAR. And this is especially true in folks with low methylation activity, which we will talk about next. Here's a low CAR pattern. So we've talked about high and prolonged. What about low cortisol awakening response? Well, cortisol does not rise in the first 30 minutes or even 60 minutes in this patient. It's completely absent. And the low and absent cortisol awakening response is a hallmark of severe or chronic depression. People often will feel like they are running on pure adrenaline when they have a low CAR because the stress response is essentially managed solely by the CNS at that point. Treatment of a low CAR usually incorporates hippocampal supportive adaptogens that restore brain-derived neurotrophic factor, or BDNF, and hippocampal volume. Here we have two different patients' cortisol patterns. The CAR is high on the left, but low on the right. The question is, which patient do you think has a better chance of having a positive response to the SSRI they're about to be prescribed? This one, right? Probably this one. SSRIs work to decrease cortisol levels and downregulate the cortisol stress response, decreasing the CAR. Now, high cortisol types often crave inhibitory and parasympathetic nervous system supports. So these are just some ideas on how you might think about treating or building a treatment plan for somebody with a high cortisol type depression. Aerobic exercise, GABA promoting and serotonin supporting hormones and botanicals can be helpful, probiotics, those sorts of things. For your low cortisol types, these folks need help with increasing adrenal output when it's too low and the stress response is inadequate because of that. So we want to reconnect the brain and the body through combined resistance training and aerobic exercise. Nutritional supports are often helpful, hormone therapies and stimulating adaptogens like cordyceps and the ginsengs. And I want to talk about a couple of slightly more complicated cortisol scenarios that you might run into when you do a DUTCH test. Sometimes the free fraction of cortisol will be low, and the cortisol awakening response will also be low, but the amount of cortisol metabolites might be massive. Even though free cortisol at each time point is normal or low, the total cortisol metabolites being elevated tells us that this patient has very high cortisol production, and they're clearing that cortisol very, very quickly. The cortisol clearance rate, or we'll call it the CCR, the cortisol clearance rate, is very fast. And this is a pattern that we often see when inflammation is a significant driver of depression. Here are all the considerations with high CCR, and all of these have associations with a depression diagnosis if you look through them. So when you see a high CCR or cortisol clearance rate, tailor the treatment to the patient. You want to assess for metabolic syndrome. Is the patient overweight? Are they weight loss resistant? Do they have high inflammatory markers, sleep apnea, or prediabetes? You want to go after exactly what it is that's pulling cortisol out of circulation, solve that problem, and break the cycle of chronic stress, right? You can throw adaptogens at it all day long, but if they're fast clearing cortisol, you might spin your wheels unless you're going after what's at the core here. What about low metabolized cortisol when free cortisol is high? Which is it, high or low? We get this question a lot. The answer is really that overall production is very low in this case, but the experience of stress will still feel very high because of that high free fraction of cortisol still hitting the tissues. And this is a stress system that's adapting to a low adrenal reserve. And here's the list of contributors to this pattern. Notice hypothyroid or low T3 is top of the list, but there are many, many other possible contributors too, from iron deficiency to mitochondrial dysfunction, eating disorders. So really want to treat the cause as much as you can. Many of these circle back to be etiological or coexisting with depression. They're related. For low CCR, you want to find and address the cause so that free cortisol can normalize. Treat your low thyroid, especially low T3. And there are studies, whenever you're thinking about therapies, you have a hunch that there's a relationship between two conditions, in this case, hypothyroid and depression. You can look for studies that use your therapeutics that you're thinking about along with treatments for depression. And a lot of times you'll be surprised. Things like this have been studied. And T3 therapy is a good example of something that's been studied to show that it's efficacious as an add-on therapy to improve response to certain antidepressants. In this case, TCAs perform the best with T3. But you want to make sure and address any sluggish gallbladder and liver function, provide your mitochondrial supports, whatever you think it is that might be decreasing cortisol clearance rate. And that is the idea behind looking at all of these inputs into cortisol function in the body. And the bottom line is treat HPA axis dysfunction in depression. It is fundamental. Now, cortisol interacts with the sympathetic nervous system. In fact, cortisol enhances the clearance of our excitatory neurotransmitters, but so does COMT enzyme. It's an enzyme family, catechol O-methyltransferase. We're going to explore COMT's connection to dopamine, norepinephrine, and epinephrine. COMT inactivates estrogens, and COMT inactivates dopamine and norepinephrine. And the DUTCH test assesses COMT activity in the context of estrogen metabolism. If COMT activity is adequate, the slider over here on the left will be near the middle or higher in the population percentile range. Low or high COMT activity in the estrogen metabolism may be informative about its activity in the neurotransmitter metabolism. So we're sort of making a judgment call. If we have very low or very high, it could be a sign of some sort of genetic SNP that is causing fast or slow COMT that might have an effect on neurotransmitter metabolism. And here's the metabolic pathway for dopamine and norepinephrine. You'll notice all the cofactors and influencers here. COMT requires a methyl donor, which is SAMe, and cofactors, magnesium and B6, to function optimally. So when you see lows for HbA and VMA, you want to check first for low COMT activity and for low cortisol production. And if those are present, always treat there first before supporting precursors of excitatory neurotransmitters, right? There's an order to things. Both high and low COMT activity can impact depression. It's not just low. When COMT is fast, we tend to see low estrogen symptoms, low dopamine symptoms, low norepinephrine symptoms, depression, brain fog, addiction, low motivation, weight gain. Fast COMT types may not respond as well to antidepressant therapies, but they tend to do well when stimulants are added. Maybe that makes sense because their excitatory neurotransmitters are so quickly metabolized. So here's a different way of looking at it. Fast COMT can lead to low excitatory neurotransmitters and the constant need to stoke the sympathetic nervous system. These are our warriors. If you see fast COMT in a patient with depression or even treatment-resistant depression, these are some of the common ways of approaching that, right? We want to temper down that COMT activity as much as possible and support the sympathetic nervous system, including dopamine and norepinephrine. We have lots of botanicals and supports that help do that. So let's talk about the slow type. COMT slow type tends to have high estrogen symptoms and high sympathetic nervous system activity with more stress perception and anxiety associated with that, and maybe even sleep problems. So we tend to see higher cortisol levels in COMT slow type with better response to antidepressants, right? These are the type that tend to have the high cortisol awakening response and the high cortisols. You want to support low COMT with methylation supports and increase SAMe, magnesium, and B6 availability to do that. COMT slow type can be due to deficiencies, and it can be influenced by genetics as well. Some people will find a low COMT or a fast COMT on a DUTCH test and go on to do some genetic testing for methylation SNPs. Slow COMT is typically treated with methylation support, which is methylated B complex, magnesium, trimethylglycine as popular choices. You can also support the inhibitory neurotransmitters to counteract some of the high stress associated with slow clearance of norepinephrine and epinephrine. And this kind of goes along with that high cortisol slide treatments. So that's COMT. Let's move on to sex hormones. And hormone balance really is the key to regulating immune and inflammatory responses that affect the HPA axis, and that's kind of the connection that we are making here. So let's start with estrogen. Estradiol is a critical factor in female depression in particular, but it also plays a role in male depression, which we'll talk about. Estradiol supports neurotransmitter balance by increasing the monoamines and decreasing glutamate activity. But most notably, estrogen is everything serotonin. It is pro-serotonin through multiple mechanisms. It increases serotonin's production in the brain. It increases the expression of serotonin transporters, which transmit serotonin's signal throughout the body. It inhibits MAOA and decreases the clearance of serotonin and also decreases serotonin's reuptake. So lots of ways that it supports serotonin. Estrogen has influence on the HPA axis as well. When E2 levels are normal, it's a modulator because it influences estrogen receptors more equally in the hypothalamus. But when estradiol levels are chronically high, its activity at ER alpha receptors can increase HPA axis activity and increase cortisol levels even. Whereas low estrogen levels, if your estrogen is too low, it binds too little ER beta. And that can actually cause the HPA axis to be more sensitive to normal stressors. And you'll see a high and prolonged CAR in those cases. So high is bad and low is bad. Goldilocks. So with E2 irregularities, the result is often depression and mood swings, fatigue, and anxiety, and sad kitty. And you can imagine with estrogen changing all the time, in females particularly, there are some key windows of vulnerability to keep in mind, and we'll go through those now. In the follicular phase of the menstrual cycle, when estrogen is on the rise, a lot of people feel pretty normal, but at and after ovulation, the drop in estrogen there will often lead to mood dysregulation in those who are sort of predisposed. And it's not just estrogen dropping at the end of the menstrual cycle. After mid-luteal, when progesterone and estrogen begin to decline at the same time, GABA, dopamine, and serotonin also flux. So this leads to the mood instability we often see in PMS and PMDD. Postpartum is another example, that extreme drop in estrogen and progesterone all at once. And perimenopause is a time of erratic estrogen levels that trigger neurotransmitter imbalances. Definitely keep in mind the perimenopausal transition as a real trigger for depression. And in menopause, sustained low estrogen levels contribute to low mood as well. On the flip side, in males, it's the opposite. So high estrogen is what's associated with depression in young males. In older males, low estrogen that's associated with low testosterone carries the association with depression. If you know your male patient is going into antidepressant therapy with low E2 levels, he has a higher likelihood of sexual side effects from his medication. And that makes hormone testing pretty valuable for identifying those who might need some extra support and be preventive. The way estrogen is metabolized can provide clues contributing, and can be a contributing factor in depression. So let's look at the metabolites. 4-hydroxyestrone and 4-hydroxyestradiol are two metabolites of estradiol and estrone that are formed through phase 1 metabolism. When they are dominant over 2-hydroxyestrogens, inflammation is a common cause. And we're hearing inflammation as an etiological factor in depression. If you see a low 2-to-4 ratio on a DUTCH test, it should make you think inflammation, right? Genetics can also be a driver. Also consider toxic exposures and even mold inhalation. These can cause hippocampal immune activation and brain inflammation that can trigger depression as well. And because inflammation is such a common driver of 4-hydroxyestrogens, when you see the 2-to-4 ratio low, look for other signs of inflammation on the DUTCH report to confirm. These are some common signs. And then use bioflavonoids and polyphenols to resolve that underlying inflammation while you explore other causes and remove them, like genetics, toxic, well, you can't remove genetics necessarily, but toxic exposures and mold toxicity if you suspect them. Let's talk about 16-hydroxyestrone. A low 2-16 ratio has a lot of drivers, many of which have some association with depression. So when you see it, you have a little bit of work to do. 16-hydroxy-E1 itself can drive depression by binding ER alpha receptors. It loves the ER alphas, much more so than the others. And so it can bind ER alpha in the HPA axis and drive up the stress response. And there's another connection too. High interleukin-6 levels in the melancholic type of depression can increase autoantibodies to 16-hydroxy-E1. And that binding of those autoantibodies to circulating 16-hydroxy can contribute to chronic inflammation. So you can kind of see how the cycle is a little bit feed forward. And so lowering 16-hydroxy-E1, if it's high or dominant, might provide a really good starting point for breaking that cycle. When the 2-to-16 ratio is low, knock down the 16-hydroxy-E1. That's the goal. Use resveratrol, use rosemary. Both have studies that show efficacy in reducing symptoms of depression and anxiety. You want to correct any known drivers, like gut dysbiosis is a really common one. Then you want to feed the 2-hydroxyestrogens by supporting with cruciferous supports. There's a handful of compounds that can increase 2-hydroxy formation and limit the 16-hydroxy pathway. And a lot of these things can be put together into one formula in medical foods and encapsulated products that lower 16 and increase the 2s. So look for those. You don't have to treat them all separately. So that's the approach to estrogen metabolism. For overall low E2 in menopausal females, we consider estradiol therapy, progesterone, and DHEA therapies. Use botanicals and phytoestrogens that mimic estradiol's neurotransmitter promoting activity in the brain, like black cohosh and dong quai and hops extract. There's lots of different ways to support even without hormones. In our cycling females, we want to really find and treat, if we can uncover the cause, that is always the best. If there's hyperprolactinemia, you don't want to miss that and go around it and try to treat with botanicals by themselves. If it's a prolactinoma or some sort of issue that needs a different type of approach. But you can break the menstrual cycle down into two parts and do follicular and ovulatory supports, and you can also support with luteal supports as well. In our male patients, often we'll support low estradiol type of depression using testosterone replacement, or increasing androgens in general. Androgens aromatize into estrogens and can be supportive through that means. And then rarely transdermal estradiol may be used in patients who are maybe using or maybe as a hormone add-back therapy. For high estrogen influenced depression, treat the cause, calm the HPA axis from estradiol overstimulation, and we use supports like FOT and maca to do that. You can increase estrogen detox with phase 1 and phase 2 movers like DIM and methylated Bs. There's lots of things you can do that are dependent a little bit on what their metabolism and levels look like. Estradiol and progesterone work synergistically in females, so progesterone follows here. Estradiol supports serotonin, dopamine, and norepinephrine, but progesterone supports GABA and dopamine during the luteal phase, in particular when its levels rise. Progesterone's actions on neurotransmitters occur through 5-alpha reductase. There's your 5-alpha reductase metabolite, allopregnanolone and alpha-pregnanediol. Progesterone also improves mood by supporting lactobacillus species in the gut, so lots of ways it supports. Progesterone, as represented on a DUTCH test, you'll find on page 1 the progesterone serum equivalent, which is a calculation from the beta and alpha-pregnanediol metabolites that we find in the urine. The alpha-pregnanediol metabolite informs us of that patient's GABA glutamate balancing potential, and low levels of alpha-pregnanediol should make you think this person might have low neurosteroid activity in the CNS from their progesterone. So low progesterone is associated with PMS and PMDD, so when you see it, it may be a contributor. But some patients do feel awful during luteal phase, even if their progesterone levels are totally normal, or even if they're high. When you give progesterone to somebody who has this issue, they might feel terrible on progesterone that you've given them in an oral or a topical. So this is called a paradoxical GABA effect, and it can be sidestepped in a number of ways. And I tried to list a few ways that have been studied under treatment options here. But a lot of us use oral micronized progesterone for those with kind of a normal GABA physiology to treat depression, because OMP is well documented to improve symptoms of anxiety and depression. It improves sleep, and oral progesterone can even be used in males, usually at lower doses to improve sleep and anxiety, and it's considered an off-label use. So let's talk about androgens. Androgens from testosterone and DHEA modulate amygdala activity directly and emotional processing. They increase dopamine. Testosterone also breaks down by 5-alpha reductase, kind of like progesterone does. And it becomes dihydrotestosterone, which is 5 or 6 or 7 times as potent as testosterone is at androgen receptors. And the urinary sign of DHT formation in tissues that's really persistent is 5-alpha androstenediol. So I think of the 5-alpha andro as a nice persistent DHT marker in urine. And 5-alpha reductase really creates the metabolites that go on to act like neurosteroids in the brain. So we do like to have eyes on these 5-alpha metabolites to understand that chemistry. And if somebody is low in that 5-alpha reductase activity, or if they're on a 5-alpha reductase inhibitor like finasteride, or they have a history of its use and have continued inhibition of this pathway and are presenting with depression, it may present an opportunity to treat, right? But testosterone affects males and females a little bit differently. So let's talk about testosterone, how it works. High and low testosterone can affect moods in our male patients. High testosterone, we think of agitation and anger and irritability. But low testosterone and low DHT, that's the driving force for depression. So think about your patients on finasteride, blocking 5-alpha with low DHT, and 5-alpha andro as being that being particularly prone to depression, and work with that. Those with low testosterone and 5-alpha andro, often we will use androgen replacements and find improvements in mood. In females, it's the high testosterone that has the association with depression. But then in postmenopause, females are more like males in that low testosterone affects moods. So it really is dependent on when you're testing, what phase of life a person is in, what you would expect to have the most clinical effect for testosterone. For DHEA, there are some studies on both high and low DHEA being associated with depression. So it's an important marker to assess. But a lot of the randomized controlled trials, even though I would say, most of them have positive findings when it comes to mood and DHEA supplementation, I think the quality of evidence for depression as an outcome is considered to be fairly low. So usually we'll use DHEA in combination with other root cause supports like anti-inflammatories, for instance. On a DUTCH Plus test, we report total DHEA on page 1. Remember, in urine, we're assessing DHEA sulfate after it was taken up into tissues and it was already been broken down into its downstream metabolites. So DHEA sulfate plus androsterone plus etiocholanolone in urine gives you more of a rough idea of circulating DHEA sulfate available to tissues. And high DHEA should make you think about acute stress. Low DHEA suggests more chronic stressors or advancing age. The approach to low androgens should involve resistance training, normalizing cortisol metabolism if it's off, and considering androgen supportive therapies like DHEA and testosterone, or even androgen supporting botanicals like ashwagandha and fenugreek, maca and shatavari. And then the approach to high androgens should include a focus on aerobic exercise rather than resistance training, and of course, the use of anti-androgens. So now we've got the stress and the sex hormones and the androgens under control. Let's dig a level deeper, and we're looking for signs of oxidative stress and neuroinflammation on a DUTCH test, both of which can be drivers of depression. Why do we care about oxidative stress? It increases cortisol production. It pulls tryptophan away from serotonin production, resulting in low serotonin and low melatonin. It also oxidizes tryptophan into some of the pro-inflammatory products like high-quinolinate, or high-quin, you might hear me call it. High-quin acts as a neurotoxin itself, so can cause high glutamate activity and excitotoxicity. We also will see an increased need for glutathione when there is excitotoxicity, and levels of pyroglutamate increase in the urine with increased glutathione need. And with oxidative stress, we see damage to cellular structures, including DNA, and that is evident in an elevated 8-OHDG in the urine. So we have lots of these markers. So oxidative stress signs on a DUTCH test are high 8-OHDG, we've got cellular damage, high pyroglutamate, glutathione activity is high, we're putting out oxidative fires constantly, high cortisol, especially the metabolites, or high CCR, and high or dominant 4-hydroxyestrogens. These are all really good signs that there's oxidative stress underpinning. And we use antioxidants to quench oxidative stress. Now, oxidative stress, remember, can increase quinolinate and cause neuroinflammation. And this occurs through the upregulation of the kynurenate pathway. So we also have several neuroinflammatory markers on the DUTCH Plus test. Remember, serotonin and melatonin come from tryptophan. So if you follow tryptophan from the very center of the schematic, the biggest box there is for tryptophan. And the DUTCH test measures several metabolites from the tryptophan metabolic pathway, really to inform about oxidative stress and neurotransmitters, essentially. So tryptophan metabolism can be hijacked here for NAD production purposes when cortisol is high or oxidative stress is high, inflammatory markers are high, and when we're inflamed. So instead of tryptophan making serotonin, instead it enters the kynurenate pathway. And we measure kynurenate, xanthionate, and quin levels, and also melatonin. Gives you an idea of what's going on. If melatonin is low and quin is high and kine is high, there's some oxidative stress and neuroinflammation. So there are 4 signs of neuroinflammation you can identify on a DUTCH test. Obviously, you want to look for quin itself as a neurotoxin that increases excitatory activity in the brain. Kynurenate is actually neuroprotective, but it can be a sign of that neuroinflammation, especially when cortisol is high. And high cortisol is kind of obvious, but also consider high cortisol clearance rate, or high CCR, as a sign of high cortisol as well, even if your free cortisol looks pretty normal. Then low melatonin is also a sign of neuroinflammation because there's less coming down through serotonin into melatonin and perhaps more going into that kynurenate pathway. So let's do a little quiz. What signs of oxidative stress do you see here? Well, they pulled out some good stuff. Starting with the oats, we have high pyroglutamate, high quin, and low melatonin. And we see a low 2-to-4 ratio, 4-hydroxy dominant. And here's a high cortisol awakening response. That's an awful lot and prolonged, right? And the free cortisol sum is pretty high, the sum of the 5 points over the course of the day. There it is. All right. When you see neuroinflammatory markers present in patients with depression, here are some of the therapeutics to keep in mind when you're building a treatment plan. A lot of them are anti-inflammatories, a lot of them are antioxidants, and some of them are antioxidant mineral supports, and use what you think would be the highest yield for each patient. And then here are my thoughts on treating low melatonin. It's almost never a standalone therapy for depression, but it can be a real helper when there are sleep disturbances and signs of neuroinflammation. So if you're going in and treating neuroinflammatory markers in particular, using a little melatonin might provide a nice bridge until their own melatonin levels can come on up and support their own sleep-wake cycles. Well, let's talk about some key nutritional deficiencies that play a role in depression. B6 deficiency negatively affects serotonin and dopamine levels. It lowers COMT activity, remember, earlier in the slideshow, and it contributes to oxidative stress by hindering glutathione recycling. So we need, in order to recycle pyroglutamate into active glutathione, we need vitamin C and B6 and NAC and glycine. We have a lot of cofactors that are required there. B6 is one of them. So look for high xanthionate and kynurenate on a DUTCH test for signs of B6 deficiency. When they're elevated, you're low in B6. B12 deficiency decreases SAMe recycling, which lowers COMT activity and increases the impact from stress. So high MMA on a DUTCH test suggests B12 is low, and it can be used as an augmentation therapy to antidepressants, particularly in non-responders. So there are a few studies that have demonstrated that. So check for B12 deficiency, B6 deficiency, and then here's one a lot of people don't know about. High 2-to-16 ratio in the estrogen metabolism, phase 1. And we talked about low 2-16 ratio earlier being associated with dysbiosis and interleukin-6 and other drivers of depression. This is the opposite. So when the 2-16 ratio is high, and this person's in the 84th percentile, that's pretty high, it can be a sign of vitamin D deficiency. And remember, D is involved in neurotransmitter balance on many levels. You could probably do a whole day of presentations on vitamin D involvement in depression when it's too low. So don't miss that sign. But let's talk about our final contributor that you can look at on a DUTCH test, the gut microbiome connection. Stress and cortisol affect the gut immune system and the microbiome. When that stress is chronic, it results in dysbiosis that can turn back around and cause HPA axis dysfunction and loss of hippocampal volume, and all of this is characteristic of depression. So it's a little bit of a bidirectional back and forth. So signs of gut dysbiosis on a DUTCH test are, of course, high indican. Indican will be elevated when there are indican-producing organisms, Bacteroides, some Clostridia species, E. coli, Prevotella. Now, some people with dysbiosis will have a totally normal indican level, so it really has to be indican-producing organisms present to give you a positive here. So if you suspect somebody has dysbiosis, but they have a normal indican, don't let that throw you off the scent. Still do your due diligence to rule out gut dysbiosis. But if you do have somebody with a high indican, that's a pretty good, you can pretty much make that call that dysbiosis is a factor. Elevated MMA, so low B12, is often a sign with folks presenting with dysbiosis, and really any of the deficiencies, including biotin deficiency, even B6 and B12, should give you an idea that there's maybe some malabsorption that could be associated with gut inflammation or gut dysbiosis. And then, of course, high kynurenate itself can be associated with proteobacteria overgrowth. So don't miss any of these signs of dysbiosis. Let's check out the organic acids page on a DUTCH test here. What do you see here that tells you dysbiosis is a cause? Should be a couple things immediately. That's right. High indican, high MMA, right? So this person is low in B12, maybe having some trouble with malabsorption, and the indican is elevated. Dysbiosis is underlying. So when you see it, treat the gut. And there are many probiotics studied for mental health and neurotransmitter balance. Probiotic selection should probably include lactobacillus component, a bifidobacterium component, and a prebiotic or a fiber component, an antioxidant component. Increasingly, we're seeing in the medical literature as increasing treatment response to the probiotics. And consider spore probiotics if IBS is part of the etiology. These are all 7 contributors to depression found on a DUTCH Plus test. Let's do a case next. So here we have a 40-year-old female, regular cycles, but she has anxiety and depression, but she's in essentially for integrative management of her depression. She has persistent symptoms of low mood, sporadic anxiety, fatigue, difficulty sleeping, and since she started her SNRI, she has experienced a decreased libido, which is unacceptable to her. She is concerned that her cortisol is high due to her, she can feel when she gets anxious, she feels like her cortisol is rising. She wants to explore that. And she's currently managed on an SNRI, a non-benzo anxiolytic, and a Z drug for sleep. So she's got, a lot of her bases covered, but she's still having some issues. She did reveal that she has a significant history of high inflammatory markers on past serum testing, but has never really been offered treatment for it. They're just watching them. So here's the sex hormone panel portion of the DUTCH Plus. This provider ordered a DUTCH Plus test to get a sense of, some of the contributing factors to see why she's not fully responding to her medication and why she might be having some side effects to her SNRI. And we see here that her luteal progesterone is totally normal as expected. She's got very regular normal cycles. We're not expecting anything to be off with progesterone here. She also has parent estrogens that are within normal ranges. We also see her phase 1 metabolism has a strong favor towards the 16-hydroxyestrone. So even though her parent estrogens are totally normal, her phase 1 estrogen metabolism pushes toward a metabolite that is very estrogenic in the HPA axis and loves those ER alpha receptors. Interesting. Causes of low 2:16 ratio, we're thinking about dysbiosis, autoimmune maybe. She's got those inflammatory markers. When she comes to us with those unexplained markers, got to think about that. But the 2-to-4 ratio is totally normal, which is reassuring. Fast COMT in the phase 2 metabolism could be contributing to persistent mood symptoms despite treatment with SNRI. Remember, our fast COMT types tend to be non-responders more so than the slow COMT type. High testosterone could be due to inflammation as well, but low for age. 5-alpha androstenediol makes androgenic activity at the tissues an absolute minimum, despite that high testosterone. So I think that high T is more of a sign and less of a tissue issue. Total DHEA, very low for age. And remember, DHEA is adrenal source. So this suggests some sort of chronic stress and perhaps that chronic inflammation, given her history of high inflammatory markers. And let's go to the adrenal panel. Here we are. Free cortisol and free cortisone sums are both low or low end. So that kind of confirms that low DHEA picture, right? Lower cortisol, lower DHEA. But the clearance rate is really fast. Another inflammatory kind of presentation. Interesting. High night cortisol, flat diurnal slope. These first 4 bullets altogether should make you think about chronic inflammation. You don't have to treat these findings all separately. They're connected to each other, including the DHEA, right? Chronic inflammation. Luckily, melatonin is normal, which brings us to the organic acids, which tell us that gut dysbiosis may be a factor or is a factor in her mood issues and probably influencing that 16-hydroxy-E1 and maybe even her testosterone, possibly. Interesting. B12 being low is likely related to gut dysbiosis and malabsorption. We can start massaging together a plan for the estrogens with the high indican and the MMA. We know we're working on phase 3 detox. And with the fast COMT, we'll want to slow it down. And she may need some phase 1 support for that high 16-hydroxy while we work on the gut health component. The link between high testosterone and low DHEA could be, and really unlikely is, inflammation in this case. The bottom line for all of that is that we're seeing dysbiosis and inflammation, right? Without the organic acids, we would be going after each hormone on its own and each low portion of the adrenal panel. Here we can see what the actual driver is with the organic acids filling in that part of the puzzle. So on the adrenal page, remember flat slope free cortisol, low CAR, high night cortisol, and high cortisol clearance rate together should be yet another sign of that chronic inflammation. And we know that the adaptogens that we choose are going to need to be anti-inflammatories as well. How about curcumin? How about saffron? These are both adaptogens that have anti-inflammatory potential and are studied for their actions on neurotransmitter systems as well, and for outcomes in depression. So we can start to build an initial RX for this first visit for her. The first thing could be for her to spend some time outside, at least 3 times a week for 10 minutes or more, the nature pill, or a forest walk, whatever she has access to. She needs some B12 in her life as an add-on therapy, some hydroxyadenosine combo for B12, and just people who have fast COMT activity, we want to slowly titrate them up to dose so that they don't have side effects from B12. So titrate to normalization of MMA. And then a mood probiotic would be nice with lactobacillus and bifidobacterium species plus antioxidants, 10 to 25 billion. Antioxidants that work nicely are things like quercetin and resveratrol. She has that fast COMT activity and the high 16-hydroxy-E1, so why not resveratrol? It's going to cover support for that mood probiotic, but it's also going to slow down COMT a little bit and decrease 16-hydroxy-E1. So a combination of trans resveratrol and quercetin could be a really high yield. And then fifth, thinking about anti-inflammatory nutraceuticals to address the HPA axis and act as an anti-inflammatory. Curcumin could be a really nice approach. And saffron has some nice studies behind it that show that it can improve sexual side effects from SNRI in particular when it's used together. So, utilize what you can find out from your searches and from what people have shown in trials, put it together with therapies that your patients are already on so that going in what's going to work or what's likely to work. A comprehensive stool test was also ordered. She had that high indican, and while we can get started with a general probiotic, boy, it would really be nice to be able to get as nitty-gritty as possible. So ordering a comprehensive stool test can help refine that final treatment plan for dysbiosis and malabsorption. Some serum labs as well to explore inflammatory markers a little bit more and other endocrine and immune inputs. And the plan's to follow up in 3 weeks with a symptoms assessment after starting the initial plan, and then review and integrate stool and serum results into the long-term kind of integrative plan. And that we expect would tackle the gut and break the cycle of chronic inflammation and restore her HPA axis. You get the sense that this is a longer-term journey that may help her end up off of pharmaceutical interventions, possibly in the future, but at very least improve her response to what she's taking and hopefully take some of these side effects off of her plate. And that's the approach. Here are some references for the treatments. I just pulled some supportive literature just to give you an idea of what's out there. A lot of this is open access. And that brings us to the end. But keep reading everything you can get your hands on. A lot of this you can read in its entirety. The research gets richer every month. Become a provider if you're not already. You'll gain access to all of our educational materials and courses on all kinds of different subjects and topics, including our new perimenopause management course. Thank you so much for listening today.
Thank you for joining us for this insightful webinar with Dr. Allison Smith. We hope you learned something useful. And watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. And you can learn more about the research behind the DUTCH test at dutchtest.com/research. And make sure to visit the Become a Provider tab to register for an account so you can gain access to even more hormone education and research. And be sure to follow at DUTCH Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.